আপনাকে আমি স্লাইড শেয়ার দিয়েছি।
শুরু করুন অফিসার।
স্যার আপনাকে আমি স্লাইড শেয়ার দিয়েছি।
থ্যাংক ইউ।
Respected speaker and foreign faculty and national faculty, Assalamu alaikum. I am Dr. Ali Nafisa, oncoplastic based surgeon, going to start our today's CME on pregnancy-associated breast cancer. Pregnancy-associated breast cancer is rare, but we have to manage the kind of patient time to time. But during the treatment period, we have to take care of mother as well as the baby. For the proper management, we have to manage this as a multidisciplinary team approach and should follow the treatment protocol or according to guideline, evidence-based, trial-based. But we know that Bangladesh have no specific protocol and guideline and no trial at all. So I have to now follow the treatment protocol of the developed country like UK, America, Australia. So today we want to learn how the management in UK. We have today's speaker, Dr. S.K. Farid Ahmed, oncoplastic based surgeon, Hospital, Buckinghamshire NHS Trust, and international faculty, Dr. Parveen Akhtar, consultant and gynae, high risk obstetrics lead, maternal fetal medicine, Queen Elizabeth Hospital, Norfolk, UK, and as a national faculty, Dr. A.F.M. Kamal, Assistant Professor Radiation Oncology, National Institute of Unity Hospital. He is also scientific secretary of Oncology Club, and through this Oncology Club, we every year we actually introduce lots of foreign faculty. The last year, 2019, they introduced 26 foreign faculty from worldwide, and through this actually Oncology Club, we learn to lots of things from S.K. Farid Ahmed, and 2017 is the first year when we actually I met S.K. Farid Ahmed sir. And A.F.M. Anwar Hussain, Head Department of Surgical Oncology, Hassania Mission Cancer Hospital, Uttara. He is also ex-head of Surgical Oncology, National Institute of Cancer Center, and General Secretary of ABSB, Dr. Professor Munira Firdausi, Professor and Unit Head of Department of Gynae and Obs, Shoraddin Medical College. Welcome you all, and I want to request Dr. S.K. Farid Ahmed to share his slide and start his speech. Thank you.
Thank you, Nafisa. Assalamu alaikum, everybody, and good morning from UK. We will be having about an hour and a half approximate timing, and there will be 2 talks, and then we have the guest faculties. All the faculties will be giving their expert opinions as well. And my talk is today about one of this rare, but it's quite important part that we come across in our day-to-day clinical practice, although rarely. It's breast cancer in pregnancy or pregnancy-associated breast cancer. The information I'm going to share is evidence-based and based on some published guidelines from the Royal College of Obstetrics, Gynae Obstetrics in England, as well as Association of Breast Surgeons UK, as well as some recent published evidences from the journals. So breast cancer remains the most common cancer in women, and the lifetime risk is about 11-12% in the world, which is 1 in 8 women in their lifetime will have a risk developing cancer. And pregnancy-associated cancer is the most common malignancy in pregnant women. And there has been overall increase the incidence of breast cancer in UK and in the world, but the mortality has fallen over 30% in UK in the last 1 decade. Now, breast cancer is the most prevalent malignancy diagnosed in pregnancy. I've mentioned is ranking up 21% of pregnancy-related malignancies. And this is commonly defined as a breast cancer diagnosed during pregnancy within 1 to 2 years of post-delivery. So during the pregnancy time, as well as 1 to 2 years postpartum, that time is anytime the development of breast cancer is defined as PABC, pregnancy-associated breast cancer, and is typically found at advanced stage. Therefore, it becomes more aggressive and has a poor prognosis because of the delay in diagnosis. And this is frequently associated with more morbidity and mortality because of that delay. And it's commonly diagnosed at 30s, median age is about 33 years. And at the end of second trimester, up to 80% cases are found in second and third trimester. So it's important to understand that vast majority of the breast cancers during pregnancy would be during second and third trimester. This is just a slide I'm going to show you where the incidence and survival, as you can see, in 1960s, 70s onwards till 2010 onwards, the incidence has gradually gone up at all age level. At the same time, when you talk about survival, as you can see, it's gradually increasing, and it's about 30% increase improvement of survival, which is quite promising. Although it's rare, and this challenging condition is managed within a multidisciplinary team approach. And we know that about 1 in every 3,000 pregnancies, the breast cancer is reported, and the age is around 32 to 38. And most of the breast cancer pregnancies can be carried out with this diagnosis. Now, what's the treating breast cancer aim is to balance the treatment for cancer and keeping both mother and baby safe and well. And one of the important messages I would like to share is the surgery is possible at any time during pregnancy. When breast cancer is diagnosed in women aged 30 years or less, about 10 to 20% of the cases may be associated with pregnancy or occur within 1 year postpartum. Now, there is always a possibility because of breast cancer related changes. Often if there is any suspicious changes develops, often it gets missed out. And there is always a small risk of delay in diagnosis. And how do you diagnose it? Usually, investigation-wise, you do an ultrasound scan, and if the scan shows any suspicious changes, an ultrasound-guided core biopsy of the breast cancer to confirm the breast cancer. I would avoid FNACs because often you miss out the potential other informations like immunocytochemistry and other informations, whether it's invasive or non-invasive cancer. The core biopsy is a recommended option. And once you get this diagnosis, worth considering doing a mammogram with a shielding to protect the baby from radiation. And the purpose of doing this mammogram is to have future comparison and to look at same and contralateral breast if there is any other changes happening.
Yeah, one second.
Now, generally, prognosis is obviously improving, as I've showed. 5-year survival is around 80% for under 50s age group. And the survival rate may lower in very young women. And pregnancy itself do not appear to worsen the prognosis. That's quite an important point. And this, if you compare with pregnant to non-pregnant women, pregnancy itself is not a factor that worsen the diagnosis, worsen the outcome. And pregnancy-associated breast cancer occurs in the younger population. Usually will have a high risk for metastasis, high-grade tumors, and usually they are estrogen receptor negative tumor, contrary to popular beliefs other way. And these younger women may have expected to have an inferior prognosis. That is what is expected. I'm struggling with my slides to move. Okay. Now, histologically, 75 to 90% involves invasive ductal cancer, and often it could be locally advanced, like T3 and node positive, and could be HER2 positive and a higher grading like a grade 3. And despite hormonal overload in pregnancy, the prevalence of hormone receptor negativity is about 60 to 70%. And that's quite an interesting observation. And this phenomenon is explained by the downregulation of ER and PR receptors with high levels of free steroidal hormones. and higher proportion occurrence of triple negative breast cancers as luminal types, as triple negative breast cancer is typical for the younger age group patients. Now, who should manage these cancer patients during pregnancy? And it should be patients who has been diagnosed with a breast lump should be referred to a breast surgeon or a breast specialist team. And following all the investigations and diagnosis made, the management plan should be done in conjunction with a multidisciplinary team approach. And this includes the obstetric teams as a core member, breast surgeons, fertility specialists, midwives, as well as oncologists and breast care nurses. In contrast to the extensive literature on treatment of breast cancer, there is no level 1 evidence on pregnancy and breast cancer for very different reasons, logistical reasons and other reasons, and maybe some legal reasons. And obviously the rarity of the condition makes it very difficult to run a level 1 evidence-based trials. But there are some observational studies available and some recommendations, but they are kind of limited. Now, young women presenting with breast cancer often have a fertility-related concerns. And it is also important during the discussion that fertility, pregnancy, lactation, all these issues are fully counseled. And after breast cancer and the availability of fertility preservation procedures, these sort of facilities should be made available to them as well. Now, women presenting with a breast lump during pregnancy should be referred to a breast specialist, as I've mentioned. The images should be done, and some other tests should be done within a multidisciplinary team approach. Ideally, an ultrasound of the breast and axilla to begin with, and if it shows a discrete lump, and axilla, if cancer is suspected, should have a biopsies done. And obviously, in that case, a mammogram with the shielding of the fetus should be done, which I've mentioned. And on the core biopsy, you would like to see the type, grade, ER, PR, HER2 status, and if there is any lymphovascular invasion, we like to have that information available as well. Now, there are, as far as image is concerned, MRI with gadolinium is not generally recommended, but it can be done if there is a genuine need with caution. So routinely, please don't do it. And for staging, simply ultrasound scan, liver, abdomen could be done, and chest X-ray with shielding could be done if needed. And one thing is important that often I see pregnant patients with breast cancers, these sort of blood tests, CA15-3, CEA, CA125, all sorts of tests are done, but they are quite misleading and confusing and definitely not recommended at this situation. Now, the staging, as I mentioned, the whole body scanning, pelvic X-ray, CT, all these things are definitely not recommended because of the risk of radiation injuries. And if you suspect symptoms suggest there is a bony involvement, a simple plain film of the relevant area and MRI to minimize the radiation exposure to the fetus is recommended. Now, there is a small percentage of cases where a consideration of termination of pregnancy may be needed and is based on careful discussion with the patient with an MDT, cancer prognosis, the treatment plan, future fertility, all sorts of points should be discussed and clarified. And that will be done with the women and our partner in a multidisciplinary team. And it's important to understand there is no proof that therapeutic abortion improves prognosis. So this is one of the important points I would like to highlight, that this abortion has got nothing to do with prognosis. There is no evidence that suggests that it improves any prognostic outlook. Now, surgical treatment includes local regional clearance, and it can be done in all trimester, which I have already mentioned before. And contrary to popular belief that mastectomy is the answer, but to be honest, breast conserving surgery is equally. It all depends on the extensity, size, and patient choice. just like non-pregnant breast cancer patients, pregnant breast cancer patients, the options for surgical things are kind of almost similar. The reconstruction option should be postponed. So that's a bit of difference until the period of after birth. With respect to pregnancy-related changes and other breast and other changes that happens that might compromise the cosmetic outcome, which is why a delayed reconstruction is recommended in this sort of situation. Now, when you talk about management of axilla, if there's an invasive cancer, you'd like to know whether the cancer has gone to axilla or not. It would be clinical examination, and more important, to ultrasound examination. And if ultrasound shows suspicious looking nodes, like a cortical thickening of more than 4 millimeter, the sonologist might offer an ultrasound guided core biopsy or at least an FNAC of the node. But the core biopsy of the breast lesion is definitely mandatory. Now, when you talk about a critically negative axilla, an ultrasonically negative axilla with the invasive cancer, and when you're staging axilla, you should be offering sentinel node biopsy. And that should be ideally be done with a technetium 99 nanocolloid injections, because technetium do not pass through placental barrier, and it has been practiced widely, and many units have used this kind of, we know the evidence suggests it's quite safe. The use of blue dye is not quite recommended because of the possible risk of anaphylactic reaction, but that reaction can happen to non-pregnant to pregnant, both sides. And we see it about 1% of patients every year will have some anaphylactic reaction, as with any other medicine. There are several publications suggested a sentinel node biopsy with blue dye is not recommended. However, these are old papers, and when I did extensive search and I have found out 2014, there was another paper published in the journal suggesting that the sentinel biopsy in pregnant breast cancer patients appears to be safe with using either methylene blue or technetium 99 nanocolloid. And this is one of the largest reported experience of SNB during pregnancy. However, my only caution to this is the number of the course on SNB that are used blue dye are quite limited number, only 7. So I would be still pause a slight caution about staging axilla sentinel biopsy with blue dye, but this is certainly is an option that can be considered, but safer option is technetium 99. And if patient presents with a positive nodes on core biopsy or FNAC proven axilla, not just simply palpable node, that means nothing. If it is tissue diagnosed positive axilla, then axillary clearance is the answer. Now, surgical treatment of pregnancy-associated breast cancer is safe throughout the entire period of pregnancy. And we should postpone operation until after the first trimester due to high risk of miscarriage. There is one paper suggested that, but although the risk is, there is not like a significant miscarriage risk. And Gentilini et al. Compared breast cancer preservation surgery with radical modified mastectomy in a set of 21 patients. And during 24-month follow-up, there was no sign of local or regional recurrence or found. Can somebody take care of the admission of attendees, please? Thank you. There is another paper published which suggested the survival among patients treated with mastectomy and breast preservation surgery. There is no significant difference. And mastectomy may be indicated during the whole pregnancy time, but in first trimester is the method of choice. But again, breast conserving surgery is equally possible. The only downside is if it is first trimester, the chances are less than 20% cases. Then there is a, can everybody mute, please?
Please unmute yourself and start, please. Purit sir, please unmute yourself. Hello, Purit sir, please unmute yourself. Hello.
Thank you. Published
you,
similar results of survival among patients treated with mastectomy and breast cancer preservation surgery. That was published by Kurer and et al. And if it is early trimester or first trimester, there is a possibility of consideration of mastectomy. And as I said, if you do need radiotherapy, it can still be given with caution with shielding. We would have our oncologist available, colleagues, the faculty member. I'm sure I would like to hear opinion about it. But as I said at the outset, that vast majority, over 80% breast cancer in pregnancy would be second and third trimester. So always consider breast conserving surgery as an option. And by the end of second and third trimester, breast preservation surgery comes into consideration very definitely, because planning of radiotherapy could be easily be made after birth. Now, chemotherapy, systemic chemotherapy is contraindicated in first trimester because of the high rate of fetal abnormality, but is safe onwards. And if you talk about the type of chemo, anthracycline regimens are found to be quite safe, but taxanes and other drugs are also found to be safe in some other publications. And usually some publications recommended that it should be reserved for high risk patients or metastatic setting. But we will hear later on from our oncology faculties about it. And there is no evidence that for an increased rate of second trimester miscarriage or fetal growth restriction or organ dysfunction or long-term adverse outcome with the use of chemotherapy. Now, when it comes to radiotherapy options for adjuvant setting, it is contraindicated until delivery unless it's life-saving or you want to preserve organ functions. For example, someone has got a spinal cord compression and acute neurological symptoms, then obviously a focal area radiation to that compressed areas would definitely improve the symptoms significantly. That's taking with shielding the remaining areas, and that's a small possibility taking that risk, but that would be a significant reduction of risk of complete disability or any other problems. The radiotherapy can be considered with fetal shielding depending on gestational age. Early elective delivery could be discussed as one of the options that needs to be considered. Routine breast chest wall radiotherapy can be deferred until after delivery, so it's an important part to remember. When it comes to hormonal therapy treatment, tamoxifen and other like immunotherapies and targeted therapies, they are usually they are not indicated during pregnancy and should not be used because of the adverse fetal outcome. And there is no data for targeted therapy, but again, it's best reserved for postpartum scenarios. And one thing is important, granulocyte colony stimulating factor, GCSF, can be used to chemo-induced neutropenia because it would have adverse effect on the fetus as well. So this can be used safely. Now, the birth of the baby should be timed after discussion with the women and the multidisciplinary team. And if early delivery of the baby is necessary, consideration of the corticosteroid for fetal lung maturation could be made. Birth should be more than 2 to 3 weeks after the last chemotherapy session. And this is to allow maternal bone marrow to recover and to minimize the problems of neutropenia. Now, the question of breastfeeding while on chemotherapy, please do not avoid neonatal, please avoid breastfeeding because the risk of neonatal leukopenia and all the other usual side effects that can affect mother can affect the baby as well. And it should be more than 14 days from the last chemotherapy session to start breastfeeding. And women should not breastfeed when taking trastuzumab or tamoxifen. The contraceptive choices for women wishing to avoid pregnancy after treatment of breast cancer should be non-hormonal contraceptive methods. So that's another important point I would like to highlight. And hormonal contraception is contraindicated in women with current or recent breast cancer, which we know that. Now, women planning pregnancy following breast cancer should consult their clinical oncologist, breast surgeons, and obstetrician. And those women who are on tamoxifen advised to stop the treatment 3 months before trying to conceive. So often typically this question is asked, and the 3 months window period appears to be safe to advise. Now, impact of pregnancy on the risk of recurrence. the women can be reassured that long-term survival after breast cancer is not adversely affected by pregnancy. So that's a quite important point to understand. Now, because of delay of diagnosis, there could be locally advanced cancers or inflammatory breast cancers, which may mimic infection, but in fact, that could be a very aggressive form of breast cancer. And this sort of treatment during pregnancy is a bit of challenge for us. And if it is diagnosed in early pregnancy, although I said that 80% or more breast cancer, pregnancy-associated breast cancers are second and third trimester. But if it is early inflammatory cancers or LEBCs, that is a bit of challenge. And as in non-pregnant cases, surgery as an initial approach to pregnancy-associated inflammatory breast cancer should be avoided and should be considered of other options like termination of pregnancies or so that enabling giving chemotherapy in advance. Sometimes we have to take those difficult decisions in conjunctions within an MGT. And there are three strategies exist. Either we could do a termination of pregnancy to prompt oncological treatment, as I've just mentioned, administration of chemotherapy with the acceptance of associated obstetric risks that needs to be fully discussed, or a delayed oncological treatment with the acceptance of associated oncological risks. So these three strategies we need to be mindful when we deal with a locally advanced and inflammatory breast cancers on early breast cancer patients. Although none of these are ideal, but deciding out of these three strategies could be quite challenging. Now, there is a review of 104 pregnancy-associated breast cancers and 564 non-pregnancy-associated breast cancers demonstrated that women with pregnancy-associated breast cancers had more advanced T and N classification and stage, and is because of the delay. And there is no difference in local regional recurrences, no difference in the distant metastasis, and overall survivals were kind of same for both pregnancy-associated and non-pregnancy-associated breast cancer. So that is another important point I would like to share. And as you can see on these curves, where on the left, I showed proportion of patients without local regional recurrence from comparing with pregnancy-associated cancer with non-pregnancy-associated breast cancer. And in the middle, there's I've showed the distant metastasis proportion of patients for both groups. They are all kind of same, and same thing goes true for survival. That shows there is not like a significant difference. Patients with pregnancy-associated breast cancer, the timing of diagnosis and treatment was the only factor associated with overall surveillance. So this is the perception that pregnancy itself poses a more aggressiveness in cancer development. But the reality is it is the delay, the timing, that is the reason for the overall survival changes. And similar review shown on Swedish Cancer Registry that compare with pregnancy-associated breast cancers with non-pre-ABCs, and that they demonstrated more advanced stage at diagnosis of pregnancy-associated breast cancer group, but they could not see any difference in mortality on adjusted analysis. And another retrospective case control study showed overall survival did not differ between cases and controls, and the diagnosis of pregnancy-associated breast cancer was not an independent prognostic factor. There are some novel clinical approaches that's come up. The predictive diagnostic approach is innovating screening programs focused on young female populations, the targeted prevention of high-risk groups, and optimized treatment concepts are necessary for better controlling of pregnancy-associated breast cancer. And recently, microRNAs have been emerged as a molecular regulators that may play a key role in pathogenesis progression or a drug resistance in different malignancies, and that includes breast cancer. And those microRNAs could be found in the circulating body fluid. And these are all future possibilities in the research setting, but that might be coming to our clinical practice in future. And those microRNAs can be found on this body fluid. They suggest that there is a role of non-invasive marker as a non-invasive marker within the use of liquid biopsy. So these are future possibility, not in current clinical practice. The expression level of microRNA-20N in pregnancy-associated breast cancer cases is to assess its role in transcription or regulation of targeted genes. For example, SPT10, PDC-D4, or BCL2, and consequently the impact on the tumor onset and progression. So that could be quite helpful for research on molecular biologies. And these overexpressed microRNA 21 may be possible indicator of a poor prognosis in pregnancy-associated breast cancers. And these microRNAs can potentially serve as a promising biomarkers for the detection of early disease stages, prediction of prognosis, and treatment monitoring of the patients with pregnancy-associated breast cancers. So that's the future possibilities. Now, coming to prognosis of PABCs, is good for women with a subsequent pregnancy after early stage breast cancer. Their published series reflect on an improvement in treatment over recent decades. I have already showed there is a 30% improvement in survival in last 30 from 60s, 70s until 2010, and is going up and up. A recent published basic study in Western Australia, it showed survival rates of 92% at 5 years and 86% at 10 years, which is fantastic. And most women should wait at least 2 years after treatment, which is often the risk of cancer recurrence time within that 2-year window. Now, women could be reassured concerning the risk of malformation in children conceived after treatment for breast cancer. And most of the available data do not show any increase in congenital malformations or stillbirth among the offsprings of women who have completed treatment of breast cancer. Historically, it was believed that compared to non-pregnancy associated breast cancer, pregnancy-associated breast cancer was intrinsically more aggressive. But the studies have concluded that this may not be correct. The review has demonstrated that pregnancy-associated breast cancers are more advanced T and N classification and stage, but there is no difference of local regional recurrence, and overall survivals are pretty much identical. So which I have mentioned that I'm just reiterating. And there are certain myths that exist with current practice with pregnancy-associated breast cancers or breast cancer in pregnancy scenarios. For example, pregnancy-associated breast cancer has worse prognosis due to pregnancy. That is definitely not correct. Pregnancy itself is not the factor. It is the delay in diagnosis is more important for the poor prognosis. Pregnancy-associated breast cancer is more aggressive than non-pregnancy-associated cancer. Not correct. Breast conserving surgery is contraindicated in pregnancy-associated breast cancer. We already have confirmed, showed on various publications, and our current practice is breast conserving surgery or mastectomy. They are same choices that can be taken on non-pregnant cancers versus pregnant patients with breast cancers. There shouldn't be any difference. Now, it is often thought that mammogram is contraindicated in pregnancy-associated breast cancers. It is perfectly safe if you shield the fetus, and you should be able to do a mammogram so that you're able to compare, and you also have a baseline information with mammogram to compare with future mammograms. So it is quite important to practice. Central biopsy of axilla is contraindicated. It is not. And the evidences so far I have provided and our current practice suggests is absolutely perfectly safe to do SNB. Another myth exists, like survival is worse in pregnancy-associated breast cancer than non-pregnancy-associated breast cancers. And I've already showed on several slides and reiterated several times that that is not the case. Mastectomy is the only choice of surgery? Definitely not. Breast conserving surgery is definitely another option. More commonly, we are offering and practicing. Termination of pregnancy or abortion improves breast cancer prognosis. And again, there's another myth. There is evidence which confirms that this is not the case. Abortion do not improve, do not make any better prognosis. So we should be mindful about when we consult these to our patients to share this evidence-based information. Now, treated pregnancy-associated breast cancer patient can't have any more babies in future. This is another myth we should be challenging because there is no evidence as such. I'm coming to end of my talk. Now, the take-home message is that pregnancy-associated breast cancer is the most common malignancy in pregnant women, and breast cancer is reported quite rarely, 1 in every 3,000 pregnancies. And surgery is possible anytime during pregnancy. The breast surgeons, in conjunction with the gynecologist, oncologist, should manage with an MDT. Breast conserving surgery or mastectomy is feasible anytime during pregnancy with sentinel biopsy using isotopes. Although I did mention that one publication was published in the journal that blue dye is also a safe option. And if patient present with cold biopsy or FNAC proven axilla, then axillary nodal clearance is the recommended option. And radiotherapy is contraindicated until delivery unless it is life-saving or to preserve organ function. And data don't show any increase in congenital malformations or stillbirth. And survival rates of 92% at 5 years and 86% 10 years for patients with pregnancy-associated breast cancers. And there is no evidence to show that termination of pregnancy in first or second trimester affects or improves prognosis. So I'd like to thank you for listening to this talk, and I would welcome any questions later on as we have got a few more parts to go through. So over to Nafisa. Thank you very much for listening.
Thank you, Dr. S.K. Farid Ahmed, for your nice presentation. I would like to invite Dr. Parveen Akhtar, Consultant Obs and Gynae, High Risk Obstetrics Lead, Maternal Fetal Medicine, Queen Elizabeth Hospital North, to share her speech. Have you got the slide share option, ma'am?
Good morning, everybody from UK, and good afternoon to Bangladesh. I am Parveen Akhtar, but I'm more known as Bindu. So hi, Humaira, I saw you entering. So basically, I work as an obstetrician and gynecologist as a consultant level. And my area of interest, as it's stated, that complicated obstetrics. It is a bit different practice in UK because the breast lies with the surgeon. So although it is a female organ, but disease-wise it belongs to the surgeon. So it's a very much, I'm echoing the same as Mr. Ahmed alluded, this is a multidisciplinary approach. It's the same topic. So some of, or maybe quite a lot of my information may be shared with Mr. Ahmed's and maybe collided with his slides. I might skip some of them. So as it established that breast cancer is the commonest cancer, both in UK and globally among the women when they're pregnant or even they're non-pregnant. So the overall, the risk for a woman to have a breast cancer is about 1 in 8 and 1 in 9. And particularly when they're pregnant, they're even little more because they are under 45 years, which is coming about 1 in 7. In 2017, in United Kingdom, out of all new cancers, 15% of them were belonging. So overall, there are about 5,000 cases per year is diagnosed among women with the breast cancer. However, the breast cancer is quite rare, as many times talked by Mr. Ahmed. And then the name we give the pregnancy-associated breast cancer is when it develops either during pregnancy or postnatally within the first year or second, or it can be extended up to the second year of pregnancy. So the group of the women we see during pregnancy is one group who has been diagnosed with breast cancer and treated, and they're going through a new pregnancy, or the group who is newly diagnosed during the pregnancy. That is the more challenging group, and that is the PABC, pregnancy-associated breast cancer. There are positive, negative. Over the last 3 decades, there has been a significant increase in the number of diagnosed cases of breast cancers, about 23% between 1993 and 2017. But the more reassuring is there's also a fall in the death in UK breast cancer related, about 1/3 fall in the death. I think this is more related to the people's awareness, more screening, breast screening, and people are uptaking more breast screening, and the improvement in the treatment with the tamoxifen, which is even extended for 10 years from 5 years, and which perhaps is another challenge to the women fertility, because women fertility and reproductive age is very limited. So I just felt that I give a little bit of small picture, because we have different specialties, and perhaps the breast surgeons knows more about the breast. But main thing is during pregnancy, we know that the lobules, which is lined by the very rapidly proliferating milk producing cells, and which also is responsible to give the density in the breast, because these cells are suspended in the vast fat lobule. And majority of the cancers are developing in the duct, which is connected to these lobules. When you looked at the risk factors for developing breast cancer, particularly during pregnancy, I think dense breast tissue plays a significant role. And that's coming from the rapidly dividing lobules. And that also interferes with the mammogram interpretation, whether during pregnancy or in the younger women. I think that we all know the risk factors, but just to have the highlighting the facts, because the younger age group may be having some form of genetically breast cancer, which is a familial breast cancer. I think we all know about the BRCA1 and 2 genes and the newly identified TP53, and there may be many more genetic factors which remains to be established. The other thing is when there is an additional amount of extra hormones, either it is coming endogenously or from the exogenous source. So endogenously, if the woman is very high BMI, then their fat layers are high. So in that one, there will be estrone, that E3 type of estrogen, and that increases the risk of the breast cancer, same as the endometrial cancer. If externally you give the HRT, which is probably not related to the pregnant group, but also related to the combined contraceptive pill, which can lead to breast cancer if you are not careful in evaluating the risk factors. The type of breast cancer in the PABC, Mr. Ahmed has given a very wonderful overview. Just to take some points from there, that PABC less than 40 groups, it's more likely related to the BRCA gene mutation. So if someone comes from that group, we need to be mindful to have a geneticist involvement to ascertain whether they carry those genes, which has an implication for the treatment and in the future as well. So the published studies has shown that if the women are in their 20s and they develop the breast cancer, there's a 33% chance that they can be linked to this particular type of breast cancer genes, and in their 30s is the 22%. The other fact is, although pregnancy is a very heavily hormone dependent, but because of the down regulations, they are actually hormone receptor negative. So if we compare to the pregnant to the non-pregnant population, And non-pregnant cohort, there is only 25 to 40% have the, there is 25 to 40% people has the receptor negative cases, whereas in pregnancy, more than 2/3 has the receptor negatives. And majority, about 80% and above, have the ductal cancer rather than the lobular cancer. But the positive thing is any lump which is newly diagnosed during pregnancy, more than 80% would be benign rather than cancerous. The way this cancer presents during the pregnancy is either present a lump, or there could be any type of changes in the skin or the nipple or the discharge or the color changes. So any changes on the breast should be taken seriously and needs the further assessment. This is the graphic presentation just to remember, but I think you people working in the breast sector sees more of this every day. So how could you diagnose easily? Before I say about this small table, I think UK has a very structured way of dealing the pregnant ladies. So it's a very, could be difficult for you because you are not in these settings. We have a setting of low risk and the high risk. So when anybody get pregnant, before they're 12 weeks, they're seen by the group of midwives, and they take the good history and identify whether there is risk factors. If this patient has a previously breast cancer, then they will be automatically referred to the consultant-led care in the hospital. But if the patient has no risk factors, they remains at the GP or the midwife group. They only come to the hospital or even outside the hospital for their delivery. So the first point of contact for any non-urgent or non-acute cases is either the GP or the midwife. So when a woman feels that there is some form of changes in the breast or there is a lump into the breast, they would then report to either the general practitioners or the midwife. And then the assessment is done initially, and then they will be referred to the breast clinic, or they can be referred to the consultant obstetrician in the hospital, who would then refer them back to the breast clinic. And the breast clinic, then they would do a further test in order to first establish, and if there is a suspicion, then to confirm the diagnosis and then the staging. I think the least is the best, that is the echo during pregnancy. So first port of test we would go is the non-invasive, that is the breast ultrasound, which provides a lot of information. And from the ultrasound, if it is benign, then that's dealt. And if there is more than benign, there is suspicion, then there is the question of the biopsy come. And I agree with Mr. Farid that having a needle aspiration might not be the best way to diagnose the breast cancer, particularly during pregnancy, because of the rapidly changing proliferative conditions of the cells during pregnancy. The other things I think he has already talked about, the mammogram, tissue biopsy, so I'm not going to repeat those ones. However, as we know that once the diagnosis is made, then treatment is based on the staging and the grading and also the pregnancy gestation. So it's important that we do the proper staging of the cancer. And given the fact that breast has the spreading mainly to the liver, lung, and bone. So if we can confine to that area, that idea about what stage they are. So basically, although we could do the chest X-ray, liver scan, but CT is not 100% contraindicated, neither the MRI. So if it needs to be done, then it needs to be done with the proper precautions, shielding the baby, by putting some measures on the maternal abdomen. And the tumor markers are unreliable, but we can do the hormone receptors, and so the, if needed, to the genes categorization. And the simplified staging, if I can highlight a little bit, the stage 1 is if the mass is less than 2 centimeters and there is no axillary lymph node involvement. And stage 2 is if it is 2 to 5 centimeters and then the lymph nodes can be involved. Stage 3 is when is the nearby structures, mainly on the skin, along with the size 2 to 5 centimeters and the axillary lymph node involvement. And stage 4 is the distant metastasis. So the main aim of treatment is, during the pregnancy, if the cancer is diagnosed, is to treat the cancer where possible. If we can't contain it, and protect the growing fetus from the hazards of the treatment. The other most important factor is, please do not delay the treatment, because that is the one which kills the woman rather than the pregnancy itself. And then when the diagnosis is made, it's not only the obstetrician or the breast surgeon, there are a whole lot of other people and specialties has role to play, particularly the clinical oncologists, which will decide about the chemotherapy, which chemotherapy is the best option, depending on the staging, grading, etc. And that's lies with their expertise. There's another most important factors during pregnancy, because this is a hormone time. Women are already down and depressed, and having such a devastating news makes them very vulnerable. So a clinical oncologist, alongside the clinical oncologist, a clinical psychologist is also very crucial. And the midwife, usually here there is a named midwife which is allocated to each patient. So they give a lot of emotional support for these women. And this is very important, because women deserve a very good mental support while they go through this journey of pregnancy, because its outcome is not only is the surgical outcome or the oncological outcome or the survival of the woman, the outcome is also the quality of the woman's life. And that also depends on how we see the woman, how we deal with the woman. And that's why the need for this multidisciplinary approach. And I have some friends, my families who are in obstetrics and gynecology, and I see that sometimes, although the breast is not their part of specialty, but can try to deal with some lump in the breast. But that may have a huge impact on the outcome, because that may delay the diagnosis, or they might mask the diagnosis or make the diagnosis even difficult, because the staging they might take some biopsy which might not be true representative of the actual condition. So I do emphasize the need for the multidisciplinary approach very much. So the mainstay of treatment is, like any cancer cases, is either surgery, radiotherapy, chemotherapy. For the breast, there is a uniquity that there is also a role of the hormone therapy, which is not perhaps is during the pregnancy, but there is a significant role of the hormone therapy, both for the treatment and the secondary prevention. The other targeted therapy is the Herceptin, and I think it has taken a big chunk of the care of the women with breast cancer. And I just highlight that there are other things which perhaps is not related to the pregnancy, is the ovarian ablation, either medically or surgically, because if there is no ovary, or ovary is quiescent, not active, that reduces the level of the hormone, and that aids in the treatment and even improves the chemotherapy work. So I think Mr. Ahmed has covered almost everything from that aspect, size, location, about the surgery, staging, and I again re-emphasize about the mental health and the women's choices. There are many women, they might think that I would delay my treatment because I would go anything for my baby. And our job is to give the information to support the woman for this journey. It's their choices. But when medically in United Kingdom, the unborn child hasn't got it right, it's the mother comes first. So we need to give the emphasis on mother, but also on the other hand, ethically, the woman has the right to decide what she wants to do. So if she feels that I would like to go to terminate, even I don't want to take a simplest risk, even very early stages of the cancer, and I would like to wish for the treatment, we need to have a joint discussion. We need to give all information. We need to properly document that one, and we need to support the woman. On the other hand, if the woman knows that she's going to die, but she doesn't want to take any risk to the baby, and she wants to delay the procedure or delay the chemotherapy, or not willing to go for the termination. So that we have to also support. So that is the practice we do, and that's our law, you could say here. Because today's talk is not only a teaching, it's just a sharing that how do we practice over here and what is the main difference. So some of the issues we do speak here, which might be very difficult in the context of Bangladesh, because our socioeconomic conditions, our religion, our women's mental setup is completely different. But one thing is, over the years, I think women has come a lot forward. So we need to support them mentally as well. So again, coming back to the treatments day is the surgery. And I think this is the breast surgeon who would perform the surgery. Our job is to guide them whether we can delay a bit surgery, because there is, although not a significant risk with the breast surgery to have the miscarriage in the first trimester, because it doesn't involve any manipulation on the uterus, but there are some conflicting information in the literature. Sadly, this is such a rare, I mean, not sadly, but this is a rare condition. So the information and the literature we have, or the evidence we have, is very minimum. Majority is based on outside pregnancy or based on the general concept of malignancy in pregnancy. So therefore, we try to say the same thing for the breast. If they're present in the first trimester, can you be delayed a little bit later to the second trimester? But there is perhaps not that significant risk to do the surgery even in the first trimester. But important thing is we try to avoid a prolonged procedure, prolonged general anesthesia, because that can impact with the outcome of the pregnancy. And also that can, because any prolonged procedure during pregnancy can lead to the DVTs, which is the clots, and that kills the woman. This is one of the commonest leading cause of maternal death during pregnancy, is having the clots, and that can be linked to the prolonged procedure, particularly in the oncology patients. So I think the shorter surgery is more welcome, and therefore the need to do the reconstructive surgery lies after the pregnancy is over. When you do the surgery in the second trimester or even the early third trimester, we need to take some precautions about in case the patient goes in early labor or needs some surveillance on both on the mother and the baby in terms of the baby's monitoring. And if it is a third trimester, if the woman presents in the third trimester, I think it's better to have the delivery for and then go for the proper operations. Or even if patient needs a surgery, and if patient requires for some other reasons the cesarean section, because we know that breast cancer per se doesn't advocate to have the baby by elective cesarean section, but patient can have the previous couple of cesarean sections or may have a placenta previa, which requires a cesarean sections. Then that two procedures can be, both surgeons in the breast and the obstetrician in the lower and can work together, and then they can do the procedures with one anesthesia. The radiotherapy. The radiotherapy is generally contraindicated during the pregnancy, and I don't go back down there. It has been said extensively by Mr. Farid. It's avoided during the pregnancy, except in the life-saving. If there is a spinal compression, then it is given, and if it is given, then the proper precaution is taken on the baby with shielding the baby. Just yesterday going through and just to rehearse my memory as well about what is the safest doses of radiotherapy which a fetus can sustain. As we all know that we talk about the first trimester and the fetal anomalies because the embryogenesis happens in the first 8 weeks. So that's what the importance is, avoiding any chemotherapy, radiotherapy in the first trimester to avoid the congenital abnormalities and the rapidly dividing the organs or the embryos. But there are other effects on the growing babies, even if we given later on in the pregnancy. So safest dose they are quoted in CDC in 2020, it's not changed. Is the same gray, 0.1, less than 0.1. And when it is increased to 0.5 or 500 rad, then the significant risks to the baby occurs. The health consequences to the baby could be anything. It could be congenital anomaly, later on the growth restrictions, or impaired brain function, or in childhood or later on cancer. So it was found that the intellectual impairment or the cognitive function disability happens when baby is exposed between the 8th to the 15th weeks of gestation. So although we may say we give some radiotherapy, but perhaps we delay a little bit of more towards the later stage of the second trimester if really needed to be. And how much radiation goes if we do just a mammogram or extra chest? It's not much. That is a gray, this is the milligray, but still it is within the expected range that may not affect the baby. That's why although when we speak, because many occasions for any other reasons, even in an abdominal catastrophe, it is the kind of bilateral conversation between the surgeons and the obstetricians, and I can see my colleagues are quite apprehensive not to put at all the CT or MRI, but if needed, we do it, and Mr. Farid, we do it, and so we need to carry on for the sake of the mother. So the chemotherapy, it's contraindicated in the first trimester, and this, it can be given the second trimester, and the safer chemotherapy, I think is the anthracycline regime 1. But if they're on chemotherapy, our aim is not to continue more than 35 weeks because of the potential risk of the bone marrow suppression. So it's better to stop the chemotherapy minimum 3 to 4 weeks before the delivery. And if somebody has been on chemotherapy, it's better to speak to the hematologist and get the GSF on standby if women leukopenia or thrombocytopenia, leukopenia or neutropenia, that can be given as an infusion. Overall, the chemotherapy has reduced the maternal mortality by 27% and the recurrence rate by 37%. Again, the Herceptin is not a talk because that cannot be given during the pregnancy, contraindicated during pregnancy and even during the breastfeeding. And although we have been known that Herceptin needs to be stopped 3 months prior to contemplating pregnancy, but newer evidence and NHS is now recommending even 7 months before you start the pregnancy. And Herceptin, as you know, has a lot of effect on the heart, and pregnancy itself is a stress to the heart in terms of output, heart rate, and so forth. So a woman needs echocardiogram if they haven't had it outside the pregnancy in order to assess the woman's heart, whether they are okay to go through the journey of the pregnancy, particularly during the labor time and the third stage of the labor. So if a woman who was diagnosed with the breast cancer, whether during the pregnancy or treated the breast cancer, so our job, it would be a shared care, multidisciplinary care. The routine antenatal care goes side by side. Some women may need a steroid even in the early pregnancy because of their intractable vomiting with the chemotherapy. And sometimes we need to consider the preterm delivery. And if we're considering less than 35 weeks gestation delivery, then a mother needs to get some steroid cover, 2 doses, 12 to 24 hours apart in order to help the baby's lung. And that decreases significantly the baby's respiratory distress syndrome when baby is born. It's important to time the delivery. It depends on whether there is any other concomitant obstetric risk factors there or not. The one good message is that many mothers, they will be thinking whether this breast cancer will be spreading to their baby, cancer cells spreading to the baby or not. But it's important to let them know that the cancer doesn't go unless there is a genetic cancer which can develop baby, but not in the immediate infancy. And many women will go through the normal labor and have a normal vaginal delivery. However, the placenta is usually sent for the histology to check whether there is a cancer cells present or not. Timing of delivery is again depends on the obstetric risk factors along with the breast cancer, whether we are going to deliver the baby because it is diagnosed late in pregnancy in the 3rd trimester, or sometimes if the disease is so aggressive, needs immediate treatment and the baby is almost 24 weeks, then this is very much conversation between the surgeon, the oncologist, and the obstetricians. The treatment can be delayed for another 2 to 3 weeks, whereby baby can be matured enough to survive on their own. And in that case, we might need to even think about delivering the baby not in the remote places. They might need to be transferred out in the tertiary care where all the facilities for the very preterms and even the age of viability babies are born. There are some studies which is done in Brussels, and they found that women who has the breast cancer diagnosed outside pregnancy or during pregnancy, out of nearly 500 cases, more than half, almost half, has delivered full-term pregnancy, but sadly 40%, more than 1/3, has ended with the termination of pregnancy and 8% miscarriage. So basically 50% has enjoyed the full-term pregnancy and another half has ended with a poor outcome or pregnancy demise. But the cancer by itself doesn't increase the risk of growth restriction or preterm or the stillbirth rate. Breastfeeding, once the baby is delivered, then the question comes for the breastfeeding. And surgery doesn't usually is a contraindication, but it can be difficult, but it can be easily then done from the unaffected breast. Yeah. same as the radiation can make the nipple very retracted, difficult for the baby to chew the nipple. Contraindications are the Herceptin, tamoxifen, and the chemotherapies. However, if the woman has stopped the chemotherapies and if it is more than 2 to 3 weeks, then she can breastfeed. One of the important thing is the contraception. How do we guide the women when they be discharged from the hospital? They have to know that the non-hormonal contraceptions are the best for them. However, if they remain disease-free or there is no recurrence for 5 years, then they can go back to the hormonal contraceptions, and there are pros and cons, but as long as the woman understands, then it is okay. There is a very important contraception, which is Mirena coil, which even is better than we call the sterilization. This is an hormone medicated coil. This has a very minimum amount of levonorgestrel, which is a progesterone. So theoretically, potentially, it may cause recurrence of the breast cancer, but the amount which is released in the systemic circulation, because it works locally, is so low that it's hardly visible in the blood. So there are the conflict of evidence that whether Mirena coil can be prescribed or not. However, I think on the safe side, if the patient is very obese and who has a double the risk of having the endometrial cancer because of the genetically or because they're having the tamoxifen, then in that context, Mirena coil can be considered. The other issues, it's later on, not immediately during the pregnancy or after the pregnancy, that chemotherapy, which can lead to the premature menopause, and that can lead to the fertility issue. So here it goes that the role of the fertility specialist, not during the pregnancy, but after the pregnancy comes or in between the pregnancy comes. I just felt that because coming from the obs-and-gynae background, that there could be some audiences who would be interested to know that they faces the challenges that the woman after the complete treatment with the breast cancer and looking for some fertility advice, how they can move forward. That's why I put that slide. Main thing is if they are premature menopause, they can still have the baby with the egg donation. So it's very important if a woman has a breast cancer and going for treatment, even before starting the chemotherapy, they should be given the advice that they can cryopreserve their eggs, or if they have a partner, even the embryos to be used in future. Whole issues of assisted reproductive technology and the in vitro fertilization is a difficult conversation in this context because they need the hormones simulation, and which can lead small risk of recurrence, but that can be dealt at the end of the fertility specialist. So if a woman has suffered a breast cancer and they would like to go for a pregnancy, it's important they need to see the proper specialists. In UK, we have a pre-pregnancy clinic where we do have the multidisciplinary people, and particularly women who has the treated breast cancer, they need to be seen in the setting of both the breast surgeon, perhaps not much, the clinical oncologist and the obstetricians to go through the woman about their options, what are the risks, and if they're going to stop the tamoxifen, when to stop the Herceptin they are on, and when to safely start the treatment. There are many women who has taken some of the oncology medications which can interfere and cause the cardiomyopathy, and same as the Herceptin, so they need an echocardiogram to evaluate the condition, because cardiomyopathy and the cardiac disease is the commonest cause of maternal death during the pregnancy. So any imaging needs to be done, which can be done before the pregnancy to start a good health if they're contemplating for pregnancy. So this is a slide which is again the same, probably Fareed has already said that pregnancy itself doesn't increases the risk of disease progression. Neither the termination of pregnancy would improve the survival rate. But if the woman is lucky enough to have the early stage of diseases, then the good survival rate of more than 90% after 5 years and more than 85% after 10 years. I think I question myself, a lot of the information and the prevalence or incidence, what we talked, because these are based on the non-pregnant population, and these are, some of them are very old. So in UK, there are very different system, and we have started collecting through the UK obstetric surveillance services, all the patients who has the PABC, and see that what exactly the prevalence in our community. It started in October 2015, but the proper result and actual incidence is still unknown. So in conclusion, the take-home message is it's a very individualized and personalized care. It's a multidisciplinary approach, and we have been repeatedly mentioning that one. And the counseling is a very important part of the overall management. Although in the Bangladesh context, it might feel very tortuous, but it's not like that bad because you are the pioneer in the breast surgery. I think we need the integration and collaboration with our obstetrics and gynecology team to be able to understand and give the combined care to this particular group of women. And we also need to take care of the mental aspect of the care condition, because it's very lonely and very psychologically tormenting, and so as the socially. So future, I think COVID has given us many negative things. Only one positive thing is they have brought together the internationally and nationally clinicians together. They are now sharing their knowledge, sharing their informations, and I'm sure they can share also their databases. And because the reality of the conditions, and because all the practice is based on the very old piece of information, and also based on very poor quality evidence, all grade 3, 4, or the personal experience, we can actually move forward for developing some international database from where we can gain experience and give the targeted care for this breast cancer in pregnancy, which is the commonest cancer during pregnancy and outside pregnancy for the woman. Thank you very much. These few slides, I just put it if I have some obstetric colleagues down there, so how different is the practice, how extensively monitored both pregnant women, their babies, and the obstetricians, because our care is very monitored at all levels. They're very much organizational based, and also women has their own organizations, and they have the every abilities and right to question the care, and they need to know the information. So I've just put those two slides. If someone is interested, they can go to the website. So in the coronavirus time, I have given some sort of link here. If somebody is interested, they can use it. Thank you.
Thank you, Dr. Parveen Akhtar, for nice presentation. We have lots of questions, and actually I want to mention that a few are senior teachers like Motiur Rahman sir, Humaira madam, Jakir sir are also joining with us, and lots of foreign participants like India, Pakistan are there. Before going to the question answer session, I would like to invite Dr. A.F.M. Kamaluddin sir to say a few word and add few knowledge with this. Dr. Kamaluddin sir, hello.
So thank you, Nafisa. Actually, the beauty of MDT is that we learn from each other. It seems that the surgeons and gynecologists had almost covered everything of oncology, and they didn't give much left to make comment. But still, let me try. One interesting thing is that the most commonly used drug in pregnancy and breast cancer is FAC, adriamycin, endoxin, and 5-fluorouracil. That is the most used protocol. And we are very scared about the adriamycin cardiotoxicity. But the few studies they have done, and they have found there is no detrimental effect of adriamycin on fetus. So they found it to be safe. And as Farid said, Dr. Farid said, the taxane is less investigated, but when we need taxane, we can use it like TNBC, or when we need high nodal burden, we can use it. So there is no absolute contraindication. Some of us may be scared that we may not be using taxane. And Dr. Farid has covered all the imaging, but one, I think for any reason he slipped, that is the PET-CT. We should not think of PET-CT during pregnancy because it causes abundant amount of radiation, which will be detrimental for the fetus. And another interesting thing is that, Allah created us in such a way that during pregnancy, there is a huge fluid in the body. So albumin level goes down. And in logic, we are supposed to increase the amount of chemotherapy to achieve the tumor control. But the study have shown that we don't need to adjust the chemotherapy drug. We need to just give as per standard dose, as per body weight. Consideration of this low albumin level is not required. So that is a interesting findings. But so even in special situation, we don't need to adjust any drug dose. And regarding the radiation, there are some data of giving some protection and other things, but my take is try to avoid radiation because there is effect of radiation. Some is dose dependent and some is dose independent. So we don't know on long term, are we doing any harm? Because this type of situation, we are doing a trade-off. We are trading with the life of the mother, and also we are trading the risk of the fetus. So the take will be, if possible, we should avoid it. And regarding targeted therapy, there was much discussion, thanks Dr. Parveen, that it is classically contraindicated, no trastuzumab yet, because it has shown some result of congenital anomalies, and there is no data about pargetumab. But a study is going on, that is mother trial. Once the study paper comes out, maybe we can make more definite comment about the use of this trastuzumab and pertuzumab in pregnancy. And finally, I would like to say that it was quite educational for me. I learned many things from both the speakers, and it is an honor to be a faculty when my grand teacher, Professor Mutiur Rahman, is an participant. Sir, salam to you and my elder brother, Professor Anwar, and I see many seniors. So thanks to the organizer for giving me the opportunity to be here. I really enjoyed and I was enlightened. And as we know that pregnancy is a desired situation and breast cancer is an undesired reality of 1 in 7 or 8 women. So it may coexist in many situations, and we need to really handle it very delicately, but very judiciously. We need to take care of the mother, but we should not forget about the kids. Thank you very much.
Thank you, Dr. Kamaluddin sir. I would like to invite Dr. Monira Firdausi ma'am to add something. Please, madam. Monira madam, are you there? Yeah.
Yes. Assalamu alaikum and good evening. First, I would like to express my heartiest thanks to Dr. S.K. Farid Ahmed for his excellent presentation and giving continuous support for our breast surgeon team. and thanks to Dr. Parveen Akhtar for her outstanding presentation. In addition, I'm thankful to Dr. Nafiza for inviting me such a nice session. Though Dr. S.K. Farid and Parveen Akhtar explained everything, I just summarized a few points for my gynecologist colleagues. We know that breast cancer, it is the most common cancer in females with a lifetime risk, and it is the leading cause of death in women aged 35 to 54 years. Royal College of Obstetricians and Gynecologists published guidelines. These guidelines provides clinical guidance on how to care for women of childbearing age with a diagnostic or history of breast cancer. It is difficult to diagnose when a woman is pregnant or lactating. When a woman presenting a breast lump during pregnancy, it should be referred to a breast specialist team. But we gynecologists should know what are the diagnostic procedure which we can do during pregnancy. Every time there is no harm, but mammography is needed if diagnosis as a breast cancer. But protection should be taken by use fetal shielding. Tissue diagnosis is with ultrasound guided biopsy for histology rather than cytology, because cytology gives an inclusive result, so that core biopsy or ultrasound guided biopsy is required. And at first, gynecologists have to know what are the treatment modalities, because when a case we found that pregnancy and breast cancer, we just referred this case to the breast surgeon's team. But gynecologists should know what are the treatment modalities in our country and what should provide them. At first, surgical treatment, including local regional clearance, can be undertaken in all trimesters. Breast conservative surgery or mastectomy can be considered based on tumor characteristic and breast size, following multidisciplinary team discussion. And reconstruction should be delayed to avoid prolonged anesthesia and to allow optimal symmetrization of the breast after delivery. We know that radiotherapy is contraindicated until delivery, but if it is life-saving or to preserve organ function, then radiotherapy may be given. And in that case, early elective delivery could be discussed with the family member. So they require the NICU support. So they provide the NICU support and they contact with the NICU team. And systemic chemotherapy is contraindicated in the first trimester because high rate of the fetal abnormality, but it is safe from the second trimester. And hormone therapy is contraindicated in pregnancy and it should not be used. All we know from our delegate presenter. But what are the recommendations for lactating mother? If lactating mother should provide her breast to her child, so women should not breastfeeding when she under the hormone therapy. It is contraindicated. And while chemotherapy, breastfeeding is not advised as the drug cross into the breast milk and may cause neonatal leukopenia with the risk of the infection. And what are the contraceptive methods that are recommended for women wishing to avoid pregnancy after treatment of the breast cancer? We know that non-hormonal contraceptive methods are recommended, but hormonal contraception is contraindicated. So these are the few topics that should be known, that should be know all the gynecologists. I think everything is discussed here elaborately, so nothing to new. I think it is clear, everybody. Thank you very much.
Thank you, Professor Munira Firdausi, ma'am. I would like to invite Dr. A.F.M. Anwar Hussain to add few comments or some knowledge to our practice. So please.
Thank you, Breast Disease Foundation, and specifically Dr.
Okay. I'd like to request
Is it Anwar bhai?
Hello.
Is he facing some network issue? Should
Yes,
we
I
ask
think.
him? Yeah, should we carry on, and then once he's back, we will ask him again. Nafisa, please
Yeah,
carry on.
I'd like to invite Dr. Motir Rahman sir. Can you hear me? Hello. Motir Rahman sir. Are you there? Okay. Hello, Motir Rahman sir, are you there? Okay. There is lots of question from chat box. I would like to invite Dr. Saidul Anwar. Please unmute yourself and ask your question. Hello, Saidul. Saidul Anwar, the question is, in what trimester breast conserving surgery can be done? Hello? In what trimester?
I think Saidul might be having network issues. But I've seen his question on chat. You happy if I answer it?
Yeah.
We have actually covered this during our talk. Basically, surgery can be done anytime during the pregnancy. The question of deciding whether it's a breast conserving surgery or a mastectomy, that is the point. And if you want to do a breast conserving surgery, then you would require radiotherapy. And if it is very early stage, sort of diagnosis, say first trimester, there is a little bit of question mark about the time delay of potential radiotherapy. But still, it can be given. So the first trimester probably best. You prefer mastectomy than breast conserving surgery. But breast conserving surgery can be done following second, third trimester anytime. So it's perfectly safe to do. I think we have got Professor Anwar Bhai
Yes.
back.
Yeah.
Should we ask Anwar Bhai to continue for your kind
Yes.
opinion and your expert comments, please?
Thank you. Actually, I have lost my connection with you. And the important thing is that due to increased nodularity and the increased density of the breast tissue during pregnancy, it is difficult to patient herself to identify the lump in her breast. This is one of the important issues. That is why most of the patients present very lately in the advanced stage. Even though regarding the treatment planning, though we have repeatedly uttered about the multidisciplinary team approach, but the more important thing in context to our country is the counseling with the patient herself and her attendant, specifically her husband. I am sorry to say, I have very bitter experience having a patient's management in our country, which I have seen about 6 to 7 years back. This is very important in the sense that the people of this country is not that much aware how to receive the treatment. The patient was diagnosed in the second trimester as a breast malignancy and got admitted for treatment in the form of surgery. But her husband from outside this country talked to me over telephone. That is total scenario and total situation. And I explained each and everything. But the important issue is that she thinks about her child, not about her wife. So finally, they left the hospital without having surgery. And hello, can you hear me?
Yes,
Hello.
sir. Yes, sir.
So they left the hospital without having surgery, and after termination or delivery of the baby, they again attend to us. But in the meantime, the stage of the disease has extended the stage 4 in the form of lung metastasis with pleural effusion, and it was horrible situation. So finally patients succumb in the subsequent 3 months. So this is very much important in context to our country, how we aware about the patient's management or treatment. So in context to this situation, I'd like to say that the most important thing is the awareness. Till today, this is very much important in context to our country. And we surgeons, not only the surgeons, gynecologists, oncologists, all come forward to ventilate about the disease pattern and disease awareness and how to tackle the situation. So lastly, a lot of thanks to organizer for their outstanding, brilliant presentation. And thanks to all the panel of experts. Thank you.
Thank you, sir. Now another question, Dr. Fasil Alam. Please, Dr. Fasil Alam, can you unmute yourself and question? Are you there? Okay, can I ask this question? I have a question. What type of chemo is a grade 2 invasive breast cancer? The patient is on 6-month pregnancy. Please, Dr. Kamaluddin, sir, can you answer this?
So actually there are many factors that we consider before selecting the chemo. I have seen the question, that is 6-month pregnancy and IDC grade 2. Only with this information, it is very difficult to comment. But as I said that adriamycin-based chemotherapy is commonly practiced. But if it is a heavily burdened nodal volume is there or the triple negativity is there, then I will be going for taxane also together. So 6 months is a fair, good time to select any chemo except trastuzumab. So we can select any chemo that will fit the histopathology and the tumor biology. That will be. Thank you.
Thank you, Dr. Kamal, sir. And another question from Dr. Aisha. Can you unmute yourself and ask this question, Aisha? Hello, Aisha, are you there? Please unmute yourself.
Assalamualaikum. Yeah, I have a couple of questions and let me recall what were those.
Please, Dr. Aisha.
So yes, the one question was, can you hear me?
Yeah, can you introduce yourself first?
Okay, this is Dr. Aisha from Pakistan. I'm a graduating fellow in breast surgery. Besides, I'm a general surgeon as well. So my question from Dr. Farid was regarding the sentinel lymph node biopsy. As it was said that ideally it should be 1-day procedure and the dose of the isotope scanning should be minimized as much as you can. So I was just thinking about that. Can we reduce the dose and this way we can minimize, and how can we reduce the dose if we could have given the injection differently, like from routine periareolar or subareolar to intratumoral or peritumoral? So I just want to need his comment that how does he inject in such situations? Because by these means we can decrease the dose, but however, I'm not sure whether this will affect the picking rate of sentinel lymph nodes or not. My second question was, we talked about pregnancy associated breast cancer, but what about pregnancy after carcinoma, following the diagnosed carcinoma? So after what time the patient may go for another pregnancy? He did talk about the tamoxifen, that it should be stopped 3 months prior to planning the pregnancy, but in general, what time delay is safe? And in a way that it should not compromise the recurrence as well. My third question was generally, what are the indications of termination of pregnancy in breast-associated breast cancers? Lastly, yes, we talked about pregnancy-associated carcinoma in the very beginning as a definition that it is cancers diagnosed during pregnancy are up to 2 years and a postpartum. As far as I have remembered, I had given one presentation, so I remember from that presentation that these cancers, though are grouped together as a pregnancy-associated breast cancer, but have some difference of prognosis. So I just want to get the comments from Dr. Farid that in his experience, what they have found. Is there the real difference in the prognosis, especially when the tumors are diagnosed after the pregnancy, but within the 2 years of postpartum? Thank you so much.
Assalamualaikum, Aisha. Can you hear me?
Yes,
Thank you very much
yes.
for all of your clever questions. I will start answering one after another. The prognosis doesn't change, and it's on my paper. There are various papers published. Unfortunately, there is no level 1 randomized trial. That you cannot really say for sure, but there are quite a few observational studies, and they're all published. And they said repeatedly, and including the New York publication books and textbooks, they say the same thing as well, that the prognosis really doesn't differ too much. And pregnancy itself is not the prognostic factor. It is because of the delay in diagnosis during pregnancy time developing breast cancer. So breast cancer during pregnancy or after 1 to 2 years within that postpartum time, the outcome prognosis was kind of same thing. The only difference is delay in diagnosis. That might change the outlook a little bit. Now, going before about your isotope things, to be honest, 20 MBQ, if you inject it same day of surgery, and it could be injected intradermally anywhere in the breast, usually the center aspects, and that should be sufficient. You probe, gamma probe should be able to pick up the signals in axilla. And more importantly, we've been practicing it almost 15 plus years, exactly same thing. And the guidelines from Association of Breast Surgery UK, as well as the Royal College of Obstetrics, is kind of same, exactly same guidelines, that it is perfectly safe. And not only those two guidelines, there are quite a few publications say same thing, that isotope injection is perfectly safe. It's not dose dependent, and there is no evidence we have found so far all these years there is any adverse effect on fetus. So I wouldn't be too much worried about the changing the dose. Simple 20 MBQ on the same day should be perfectly fine if you want to use that, injecting intradermally. And that would be usually be practiced at the nuclear medicine people who would be injecting this. But another presentation, another section I talked about dual tracker. If you use blue dye, which is only one publication which showed is perfectly safe. Because blue dye is not widely used, that probably is the reason that we are saying caution or not to use it, but it can still be used. In that case, if you use any dye, forget about cancer during pregnancy for any cancer patients, the question that you asked whether it should be peritumoral or elsewhere, if you could inject 2 cc blue dye or any dye at subareolar region deep and give a good massage for 5 minutes, it really, that dye goes through the lymphatic channels to the lymph nodes, finding the blue color. So it doesn't have to be intradermal or peritumoral. We have evolved in last 17, 18 years with our practice of doing sentinel biopsy for breast cancer, that now we practice more regular basis, that you could inject subareolar and give a good massage. It doesn't have to be peritumoral or intradermal. And your another question was, I missed, I forgot about your another question.
I can answer that one.
Please, Bindu Appa, go ahead.
I think one of our question was in relation to what is the optimum time interval between the completion of the treatment and going for a pregnancy. So our RCOG says it's 2 years because the risk of recurrence and any cancer is within the first 3 years. But I think this is very generalized thing. We have to take case by case. If someone who is the hormone receptor positive, and they would be on tamoxifen. And as you know that recently they have increased the duration of tamoxifen even 5 to 10 years. And if a woman, she is already 35-year-old, and she had the breast cancer treatment, if they wait for another 10 years to go for a treatment, then how is her reproductive life goes? And where is the quality of the eggs she produces? And what is the risk of the Down syndrome? And what is the risk of miscarriages? So these all needs to be taken into consideration. So I think after the positive trial, you would know better whether the interrupting the tamoxifen and going for a pregnancy, does it impact on the future women's survival? And also, if the woman has a very early stages cancer and doesn't require more than surgery or a bit of chemotherapy, then they can perfectly all right to go for pregnancy 2 years. And even some women may go just after surgery within the first year. It all depends on their own age, their preferences, the staging of the disease, the grading of the disease, and what they are looking for. The other thing is, if the woman is a very advanced stage cancer, so her lifespan is very limited. So we have to be honest, and that's what we do practice here. I know there could be a lot of differences, Mr. Anwar, but we have to be, we give them the actual fact and they make the decision whether they would go for the pregnancy or not. We actually warn them probably not to go for a pregnancy because that will compromise their own life. That will bring a baby in the world who would be very unsupported for the rest of the life. So I think it's my answer to that one. There is no specific rule, but generally speaking, 2 years. We used to say 5 years, it's gone to the 2 years now.
Thank you.
Another question from actually, what about SLNB with ICG plus spy camera? Actually,
Asking this question.
Who is this from? Actually, I can't chat box privately ask this question, so I cannot mention. Please. What about the
I don't
SLNB
think we have got much experience about this spy camera thing. If you want to stage axilla sentinel biopsy with isotopes, is perfectly widely accepted as a recognized safer option. But if there is any newer techniques, I don't know whether there is any published evidence or anything. I haven't come across any published evidence. I mean, the question, those who is asking this question could share if there is any published evidence. I'll be happy to take.
my another question.
Can I say in this regard?
Please,
Yes,
sir.
please.
Can I say? Actually,
Please.
indocyanine is used in the spice. Hello. Indocyanine is used in case of pelvic surgery to identify the lymph nodes, but usually till today it is not used in the axillary dissection. So far I know. Thank you.
Thank you, sir.
Thank you very much. Thank you very much. As far as pregnancy with breast cancer, that is not even been studied. So I would not really recommend to use that unless there is some published evidence. But Anwar bhai, I entirely agree with you. That's absolutely valid point. Over to you, Nafisa.
Okay, thank you.
Thank you, sir. Another question from Dr. Nabil Fahmi Ali. Dr. Nabil Fahmi Ali, can you unmute yourself and ask the question? Nabil Fahmi Ali. Hello.
I think Nabil was asking more information about the isotopes, the papers and evidence, and I can share him personally about all this published evidence. There are so many published data and evidence, and there are so much information on guidelines from Royal College of Obstetrics as well as an ABS, Association of Breast Surgeons UK, and many other parts of the world that they are recognized, well-established practice. We can share you all those data, and in fact, if you could email me, I can send him all the informations for knowledge sharing. I think there is a question from Bari. Did you see that one?
No, sorry. Another question from Asifa. Bari question, please. I can't see this. Dr. Asifa, can you unmute yourself and ask the question?
Hello.
Hello, hi. Please ask your question.
Assalamu alaikum. I'm Dr. Asifa Tasnim. Firstly, thank you all for your nice presentation. It was really informative. I have got answer for most of my question, although I have one question, that is, can those anti-cancer drugs can cause infertility for future pregnancy? Is there a chance of infertility?
Yes. The chemotherapy, they can cause premature ovarian failure, which leads to secondary, then if premature ovarian failure, then that leads to infertility, because you cannot, one of the cause of the infertility is the ovulation, isn't it? One of the most common cause. So it does lead to the infertility. That's why the recommendation from UK RCOG is even before commencing the treatment, we need to have conversation with the patient and the partner, if the patient has some partner or husband, about the implications of the chemotherapy. And she needs to know what is the risk of the premature ovarian failure, what is the risk of her future fertility. And if needed, they may need to refer to the fertility specialist to have the further conversation. So the answer to you, there are issues and there are solutions as well. So the fertility can come completely from the premature ovarian failure, or even some ovulation issues with the stopping and getting this all kind of anti-hormones. And that leads to the dysfunctional uterine bleeding, endometrial hyperplasia, and eventually to cancer, because there is a twofold increased risk of endometrial cancer, even with all the tamoxifen we are using. So if the woman has the options, if she's going before chemotherapy, if our system in Bangladesh allows, there is the cryopreservation of the women's oocytes, or because in our country, majority of the women are marriage, they can have their embryo freezing, and the frozen embryos can last 10 years and even can be 50 years. And the quality doesn't goes off with time. So if the woman before starting the chemotherapy, if they are desperate, they can have the through the IVF centers, the egg collections, and then the sperm and the embryo is formed, and they can preserve that one and they can start the chemotherapy. There are two issues with that one. They can have some delay with their treatment of starting the chemotherapy. On the other hand, because these IVF cycles or any kind of assisted reproductive techniques, it involves the preparing the woman, even before collecting the eggs, it needs some sort of hormone stimulation. And even having the surge of the hormone to get the ovulation done, to get the couple of extra eggs done. And that leads to some surge of the hormones in the woman's body. Whether that has an impact on the increased risk of recurrence or increased aggressive amount of breast cancer, we don't know yet. There is not much evidence, but this is the potential thing. But many women do go for the egg preservation. So that's that. And if there is a premature ovarian failure, there is that ovaries are gone, then they have the options to go for the egg donation and the IVF. And that's a very common practice. There are loads of women goes for the egg donations, and they can go all over. Does it answer your question?
Thank you, ma'am. My own question to Dr. Munira Ferdowsi, ma'am. Country, is egg donation and egg preservation technique available, Dr.
Bangladesh.
Hello. Actually, I have no idea about this, that in our country it is present or not. Anwar sir.
Yes, Nafisa, in our country, egg donation and egg preservation is possible in Apollo Hospital, in ICRC. There are too many infertility centers in Dhaka, so they are doing this.
Thank you, madam. My another question is during pregnancy, when on is and we hope that infertility may develop after this as chemotherapy started. But when this egg can when? Thank you, ma'am. Parveen Akhtar, madam.
Couldn't hear your question. Can you repeat, please?
When we will take this egg, as patient is pregnant and we started going to start chemotherapy second or third trimester, but egg, when we will take the
egg, because egg is all, you have already the embryo, you have already the pregnancy, so there is no question of egg collections. It is the egg is collected when the woman before going for the chemotherapy. So that with the chemotherapy, there is a risk 20 to 70%, which is wide range that women may lose out the function of the ovary, although they are young, but because of the side effects of the chemotherapy can make the ovaries non-functional. So without the ovary, without the eggs or oocytes, whatever you say, because you know that primary oocyte, secondary oocyte, then the ovulation starts, ovulation happens, and that's what the egg is. And without that ovary not functional, you cannot be pregnant. So chemotherapy leads to ovarian failure, leads to infertility by suppressing the ovaries. So the only way the woman can get pregnant then, if the ovaries are non-functional, is to borrow these eggs from somebody else. And that's the egg donation. It is, I mean, in the context of, there is loads of ethical, religious, personal issue, even in this part of the world. This is very much personal. So these questions, because we have the HIFA, Human Embryology and Fertility Act, and they deal with all these things because it is a huge chunk on, again, psychological issues. The breast cancer, you do only the surgical part, the amount of trauma, it's the psychological, women lose out their femininity, the psychology about lose about their image going down, their fertility goes down, relationship breaks down, there are loads of, and then even the challenging journey through the pregnancy, going through the route of the egg donation. So they have to go through a lot. So there is a very good role to be played by the clinical psychologist. And that's what it is, the need. As a woman, I know everywhere still, because this is a sensitive issue, I understand completely in Bangladesh why they go to the first gynecologist before they come to the surgeon. And I'm glad, Nafisa, seeing you, and there are many, you told me that they are coming to the surgical field. And I feel really proud that you people are taking the flag for us. It's important because women barrier, like even Mr. Anwar just mentioned that the challenging experience he had with one couple where the husband dictates, even he has dictated the woman's life. That's not possible here. The woman whole treatment is delayed because husband did not want that treatment to start. He cared for his unborn child. But that's in a way, I mean, it is very difficult. If that was a face-to-face consultation, then impact could be different. But again, in our society, because it's also the culture in society, it's a lot of domination from that aspect. Not everybody is mutually agreeing that one. So what happens even here, if we feel, because we very much welcome the husband or the partner to be in the consultation. But if we smell anything in that direction, there is a dominance going on, it should be taken very different way, discreetly. Either he has to leave or we need to make another consultation with the woman, because it's the woman's body, it's the woman's life. So she needs to take control and she needs to make the decision. It's very good the partner and the husband is there. But if the woman says, no, I agree with my husband, and I'm not under pressure about this opinion, then that's fine. But sometimes they just sacrifice like that. So challenges is here as well, but maybe a different level.
Thank you, ma'am. I would like to ask a question to Dr. Kamal sir. Hello, Kamal. Can I ask you a question? Sir, we know that radiotherapy is contraindicated during pregnancy, but when that sometimes the such a biological character of tumor that no need of chemotherapy. So surgery in the second trimester and no need of chemotherapy. So how long we have, wait for the radiotherapy?
We can wait up to very safely up to 8 to 12 weeks. And so it is not an issue. When we are doing a surgery and we are considering that we are not giving chemotherapy, we will be giving only radiotherapy. If it is a mastectomy, then we are quite safe. Even if it is a breast conservation, then I think the discussion should be, as Farid said, we should shift the surgery date a bit later on, so that after the surgery we get enough time, this window period of 8 to 12 weeks, to start a radiotherapy. So that is how we should make a plan, because it is not that making 1-2 weeks will make a good difference. So normally the recommendation is we can go up to 8 to 12 weeks, but in extreme situation, you can go up to 6 months. But normally it is recommended for 8 to 12 weeks.
Sir, suppose another question. Suppose one patient came to us the 6 months of pregnancy, and it is a large tumor, may need mastectomy. But if neoadjuvant chemotherapy given, so may cause misconducting surgery. So can we give, as second trimester and third trimester is safe for chemotherapy, can we give the neoadjuvant chemotherapy to downstage this tumor size for misconducting surgery?
Of course, that was the main discussion. We can give chemotherapy. Even we are telling first trimester is risky, but there are now papers coming out, even in first trimester also you can give. So from second trimester onwards, if it is say the case that Dr. Anwar was telling, the patient came for surgery. So this type of situation, I mean, this is advanced disease. The ideal, we should not make any change during the pregnancy, breast cancer and normal breast. It is the same treatment. So if it is a neoadjuvant required, give neoadjuvant. If it is a surgery required, do surgery. The only thing is delay the radiation and the hormone and the heart safety. These three you should delay. Otherwise, everything is same. And there was a question about the prognosis. Farid was answering very nicely, but I want to add one interesting fine thing, that probably breast cancer and pregnancy is giving a better prognosis than normal pregnancy. Answer is why? You see, the majority of the patients are having bad biology, high nodes, ER negative. So these patients do bad. But surprisingly, the outcome data of breast cancer with pregnancy is really wonderful. So probably it is a blessing in disguise that God don't want to put two curses on the same lady. So when she is having a sufferings like physiological sufferings, so it is giving an additional, we don't know, maybe giving some benefit. That's why the outcome is, if you consider those factors, some authority and some people are telling that probably this group are getting a better prognosis than compared to normal breast cancer. So could I answer you, Nafisa? Definitely you can give neoadjuvant, plan the surgery, then go for adjuvant treatment, whatever is required, but forget about hormone and trastuzumab during pregnancy and radiation, these three.
Thank you, sir. Sir, maybe one question from Bari, Dr. Bari. I can't see this question. Farid sir. Hello. You asked about Farid sir.
Yes, thank you very much, Nafisa. Dr. Bari, are you there? If he's not, I've seen his question on the chat. He asked if a patient has got a stage 3A, like an local advanced breast cancer, and if it is in first trimester. So on my slide 30, I've answered there are 3 strategies. One is some difficult decisions sometimes we have to take. One is we talk about termination of pregnancy. One is starting administering chemotherapy, which Kamal Bhai has just even reconfirmed that chemo can even given first trimester, and delayed oncological treatment. There are 3 strategies that can be taken. And with a thorough counseling, a decision needs to be taken, and they have to give them full plus and minuses. All the pros and cons needs to be clarified and come to an agreed decision with an MDT and share this decision. So this sort of advanced local advanced breast cancer, or it could be an inflammatory breast cancer, it could be on first trimester. But the treatment plan, as we have so far presented, and all the honorable faculties have shared their expertise, the comments, the answer is already given, I think. Bari, are you there?
Thank you, sir. So I want to invite you our next session on the our next session on 25th July. The topic is interventional breast imaging, better diagnosis and better management, will presented by Dr. Humayra Islam Khan, consultant sonologist, Anwar Khan Modern Medical College. At the same time, please join with us. And I like to thank all the faculty from home and abroad for supporting us and enrich our knowledge. And thank you all.
Thank you.
Thank you so much.
Thank you, everybody.
Actually, I missed the.
Thank you,
No, sir,
Nafisa, for a wonderful host. Thank you, Farid, for inviting me. And it was my pleasure to get connected to Mr. Anwar and others.
Thank you very much. Thank you.
Okay.
Thank you. Thank you.
Thank you, Dr. Farid.
Pranava.
Thank you, Dr. Nafisa, and Dr.
Yes,
And
sir.
a lot of thanks to Dr. Parveen Abba.
Absolutely. Thank you very much. Thank you all. Assalamu alaikum.
Thank you.
Assalamu alaikum.
Allah Hafiz.
Allah Hafiz.
Allah Hafiz.